Hello, my name is Ever Cedeño. My topic is Markel-Cell Carcinoma. Definition: Markel-Cell Carcinoma is an aggressive cutaneous neuroendocrine tumor that is associated with viral virus infection, immunosuppression, advanced age, and the exposed patients generally have red or pink nodules that are in areas exposed to the sun. One video.
The skin is the largest organ of the body. It serves many important functions, including protecting the body from infection and regulating body temperature and fluids. The skin is primarily composed of 3 layers. The epidermis is the outer layer of the skin and contains basal and squamous cells. Melanocytes are also found in the epidermis. These are cells that contain pigment, which allows the skin to tan and which also protect the deeper layers of the skin from the effects of UV sunlight exposure. The dermis, which lies below the epidermis, contains blood vessels, connective tissue, hair follicles, and sweat glands. The subcutaneous layer, which is the deepest layer of skin, contains fat cells and collagen. Skin cancer occurs when there is an uncontrollable growth of abnormal cells in a layer of the skin. There are 3 common forms of skin cancer that are distinguished by the types of cells affected. Basal cell carcinoma is the most common form of skin cancer. This type of skin cancer does not typically spread, but does require treatment. Basal cell carcinomas most often develop in the areas of the skin exposed to the sun. Squamous cell carcinomas develop in the middle layer of the epidermis. This type of cancer can spread and can be life-threatening if not treated appropriately. Abnormal growths of melanocytes, called malignant melanomas, are the most aggressive form of skin cancer. Melanomas can spread quickly to other parts of the body and to organs. This type of skin cancer can be fatal if not detected and treated early. People with fair skin are at increased risk for developing this form of cancer. Increased sun exposure and a history of sunburns increase the risk for developing skin cancer.
Application in medicine. The application that exists of the type of malignant cancer in medicine go exclusively. During surgery, your doctor removes the tumor or avoid with normal skin, water, and light. Radiation therapy. Radiation therapy involves directing high energy rays, such as X-rays and protons, into cancer cells. To video.
Basal cell carcinoma is the most common of all skin cancers, and for most people, it's little more than a nuisance.
They've found different spots mostly on my arm and on my back. But that's from hanging out in the sun when I was younger.
Bob Davies has had several close encounters with basal cell, but he's always come away with a clean bill of health. Although it rarely metastasizes, the cancerous lesions can spread.
Although they have a very small risk of metastasizing, which means moving to another part of the body, they can get invasive and get deeper and bigger.
The standard in care is to have a skin cancer treated by a dermatologist. Someone with an aggressive basal cell cancer likely faces additional treatment, a more traditional protocol used to destroy cancerous tumors.
Sometimes radiation therapy can also be of help because they tend to be sensitive to radiation. So the mainstay of treatment for the early ones is surgical removal and sometimes some radiation therapy also.
Basal cell also tends to be more disfiguring and problematic if it's left untreated for many years. It often appears as a waxy bump and is most common on the face, neck, and arms.
people are living longer, and the longer we live, we've had more chance for these mutations and cancers to develop.
The takeaway Bob learned is by dealing with skin lesions when they're a small inconvenience makes them less likely to turn into a real pain.
It's very quick and very fast, and it's a good, safe thing to do.
For Lee Memorial Health System, I'm Amy Osher.
Pros and cons. Pros. The possibility of human cancer pathology is a third more than one entrainment to the oval to the elimination and from the body. Cons. The downside to this and other cancer is that there is a chance that it will spread quickly to the lymph tissues. 3 video.
In this video, we're going to be talking about Merkel cells. Now, what Merkel cells are, they are mechanoreceptors, so they're able to receive any kind of mechanical stimulus coming from outside and transmit it to our brain. So they are situated in the deepest layers of the skin where they receive some kind of stimulus. They have a sort of oval shape. And as you can see in these two pictures I got from Wikipedia, they are situated right under the epidermis. And the epidermis is the top layer you can see. Right below it is the dermis. Now the dermis is made out of connective tissue, while the epidermis is epithelial tissue. So the dermis is actually vascularized, so you're going to see blood vessels in it. Well, you're never going to see them in the epidermis, but the epidermis is also innerved, so you're going to have nerve terminations in the epidermis as well as in the dermis. Merkel cells are part of the non-keratinocytes. The keratinocytes are the typical cells of the epithelial tissues. They produce a protein, which is keratin, which is present in our skin, our hair. So keratinocytes are the most present types of cells in our epidermis. So non-keratinocytes are Merkel cells, then melanocytes, which are the cells which produce melanin, which give you skin color, and
Ecuador. Guayaquil, Ecuador. Markel-Cell Carcinoma (MCC) was first invented by Topper in the 60s for naming trabecular carcinoma due to the clavicular that is one of the forms of the presentation of neoplasia. Video 4.
I think there is very good data available on something which is new, and this is a dermato-oncology meeting, which means cutaneous malignancies. And the news here is certainly also the Markel-Cell Carcinoma data. I like them very much. It's two drugs which has been used. One drug is a PD-L1, a PD-ligand-1 antibody called avelumab, and the other one is a PD-1 antibody called pembrolizumab. And these two agents showed very good results. One was published in New England Journal of Medicine. One will be published by next week in Lancet Oncology. And I can only say it's very good results, and we can define a new standard of care. So I would say forget about chemotherapy for Merkel-Cell carcinomas from, let's say, now or let's say early next year. And so the immunotherapy with checkpoint blockade is certainly replacing the current chemotherapy, because more responses, longer responses, and obviously longer responses cause a better overall survival, and this is what we are interested in.
Conclusion. The Markel-Cell Carcinoma patients treated in this article is a type of malignant cancer that appears as the nodule astomeric associated with polyomavirus infection, so she had to undergo and amputation of the affected finger to prevent the spread of the carcinoma. It's moved or dissected from the lymph nodes. Thank you so much. Be afraid.
My name is Sandra D'Angelo. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center. What's been exciting in caring for Merkel cell patients over the last few years are the new therapies that are emerging. I think it's very important that patients seek care in an academic medical center that has a large volume of Merkel cell carcinoma patients. They should really see a surgical oncologist with specialty in skin cancer management. Early stage usually comprises of a local therapy approach, surgery and or radiation therapy. And later stage usually is comprised of systemic therapy or a drug therapy that enters through the veins and kind of circulates throughout the whole body and treats all of the disease. When I first started practicing at Sloan Kettering, caring for these patients, the only tool I had available for these patients is really chemotherapy. And while chemotherapy helped our patients for some period of time, it just wasn't good enough. But really the evolution of immunotherapy is really what's led to a marked improvement in the lives of our patients that are treated with immunotherapy with drugs such as avelumab or pembrolizumab are really living longer with their disease and maintaining good quality of life. We know that we're helping half of our patients, and now we need to think about ways to help all of our patients. And different ways to do that are one, understanding which patients are benefiting from therapy and which patients are not. And then for those that are not, what can we do to broaden the options for those patients? Thinking about combining a few different drugs. I think that the field is really at its infancy, and the possibilities are endless. And it's a privilege really to be part of this world where we're really trying to unravel new ways to treat what was referred to as a deadly cancer in the past.